Order. Welcome to this morning's committee. I'd like to welcome everyone to today's committee. It's the first evidence session on Black maternal health, and I'm standing in as the chair today, the acting chair, because Layla Marian is off on paternity leave right now. So she'll be off a few months, so I'm standing in. But I'd also like to welcome Sarah, who's a friend of mine. She chairs the Women's and Equalities Committee, Sarah Owen. So welcome, Sarah. We really appreciate you coming today. And I'd like you, the first panel member, to introduce themselves. Now, there was supposed to be two of you, but unfortunately, your sister's not very well. So Tinuke, have I got that right?
You have Tinuke,
yeah. Can you introduce yourself, please?
Yes, sure. So my co-founder, Chloe, couldn't be here today, but my name is Tinuke Awe, and I'm the co-founder of an organisation called 5 Times More, which is dedicated to changing and highlighting Black maternal health outcomes in the UK.
Thank you, Tinuke. What I'll do is I'll hand over to Ben to ask the first question. Ben, over to you.
Cool, thanks. Thanks very much, Tinuke. Thanks for coming in. And it's really good to see you. And I watched your TED Talk and brilliant what you're doing. It's just a tragedy that you have to do it.
Yes.
But not everyone may have heard what you had to say in the TED Talk and stuff. So I just wonder if you can tell us a bit about your own experience, which led you to co-found 5 Times More.
Absolutely. Yeah. And just on a side note, if nobody has watched the TED Talk, I do implore you to go and watch that because it's fantastic. I am a little bit biased because obviously I'm in it. But we did a TED Talk in January, which was absolutely phenomenal. It's been really well received. So I was pregnant in 2017 with my first child. And it was a relatively interesting pregnancy, to say the least. I was showing signs of high blood pressure and protein in my urine from about midway through the pregnancy, but it wasn't picked up until right at the end that I actually had preeclampsia. And as you know, preeclampsia can be quite life-threatening for both mum and baby, but that wasn't picked up until right at the end. And I'll never forget the look of shock on the midwife's face when she saw me. At the last appointment, I looked like I had swallowed a house. I was so big due to just all the water retention and the swelling. And so she told me to go straight to the hospital, where I was told I had preeclampsia and that I would need to have been induced. The process wasn't entirely explained to me properly. I felt like I was definitely coerced into it. It was more the conversation of, you can't leave this hospital without having the baby, as opposed to explaining what the risks of induction are, because I feel like if I knew what the full risks were, I would have maybe taken a few steps back just to, weigh up all my options. But basically, I was told, right, you've got 24 hours for the hormones to kick in with the induction, and a few hours later, obviously, I now know I was in labour, but I was experiencing quite a lot of pain. And I asked the midwife to check me over, and nobody checked me. No one believed I was in labour. And it was just a series of really unfortunate events.
They didn't believe you were in labour?
They didn't believe I was in labour.
What, you said I'm in labour, and they said...
Yeah, they didn't
on what
check.
grounds they didn't check?
They didn't check. They didn't check how many centimetres I was dilated. They didn't check anything. It was just... I remember one of the midwives saying, you're making this much noise now, what will you do when you're actually in labour, without realising I was in labour? So I was left for a few hours just to kind of, I don't want to be too gory, but we are talking about maternity here. It was a really terrible time where I was on the toilet, I was vomiting, it was awful. And then my waters broke and they checked me. And I realised I was almost ready to push. And again, another look of shock I won't forget. That's plastered in my mind, of the midwife who pressed the emergency button, loads of people coming in, baby's heart rate was dropping. It was, it was quite a scene. But by this point, I was exhausted. I was so tired. I passed the threshold for any pain relief. And I couldn't push. I couldn't push, but they were like, at this point, I was 10 centimetres and they were urging me to push, and I just couldn't because I was so tired of that experience of, I told you I was in labour, I'm in so much pain, and it was just really awful. I ended up having an assisted delivery. I don't think that's the end of the world, to be honest. So many people have assisted deliveries all the time, and it's just part and parcel. Nothing it comes out of it. But I do feel like it could have been avoided if someone had just checked me over in the beginning, if they believed me when I said I was indeed in pain.
That's really quite shocking. That's your experience, and you've also talked to lots of other black women and black mothers. And what's the most common themes that you're hearing? What are the things that you're hearing? Is it about being listened to? Are there other things that come out? And what makes you think it's a particular experience that black women have as opposed to all women?
Absolutely. So at the time of founding 5 Times More, I was running an organisation called Moms in Tea, and I'm talking to loads of black women at the time. Thank you. Talking to loads of black women at the time, what their experiences were like, and it was just really shocking, very similar, like not being listened to, emergency situations about sepsis, some young moms being sent home when they didn't believe that, they thought, oh, you're sweating because you're breastfeeding. Actually, they had retained placenta. All of these kind of things where people just aren't believed when they speak up. I guess to your point of how do we know it's particularly black women? So we've done some research in 2022. So we've got the Black Maternity Experiences Report, which is the largest report on black women's experiences to date in the UK. We do have a survey that's currently closed. We're crunching the numbers at the moment to be able to give some new data, but I don't have that right now. So I'll be giving some quotes from our last report, if that's okay. But in terms of some negative experiences we heard from there, basically there was some information around the attitudes, knowledge and assumptions carried by health professionals when it comes to black women. And some specific quotes are, I had an episiotomy and the stitches fell out. I am at high risk from infection due to my sickle cell, and they kept refusing to have a look. By the time a doctor looked, the stitches had fallen out and was infected. This then triggered a sickle cell crisis. I've got one here about an African pelvis. I had to go for a 36-week scan, and there were concerns that my daughter was not growing. At the scan, the doctor commented that the West African women hold babies higher up in their pelvises, so it was just baby's position. Another one here says, one midwife, when doing the sweep, said that the reason for dilation taking so long for me was probably due to an African pelvis. Even though I was on pain relief, I was mortified that she actually believed there was such thing as an African pelvis. Another one here about the stereotypes of being strong as a black woman and being able to handle pain. One woman was told that she was big and strong, so there was no need to worry. And another woman recounted that she was told, women like you should be able to handle the pain. And I particularly wanted to talk on this. I find that bit quite ironic, because if the belief is that black women are stronger and that they can handle the pain, surely if a black woman is telling a health professional that they are in pain, they must be at their absolute limit and threshold, so therefore they shouldn't be dismissed by the very standards.
Absolutely right.
Yeah,
absolutely right. I remember seeing I think it was during COVID, or a Panorama program by David, what's his name? Great actor, played the head of the CIA in Homeland. Oh gosh, I know exactly who you're talking about.
David Hayward, yeah.
Hayward, yes.
Yeah, Hayward. And it was really shocking. And there was a mother talking, a mother in her 40s, talking about her daughter had gone to the doctor, and she'd complained of being in pain, and she was told that black women could suffer more pain, and she said, and they told her that black woman's pelvis was different, and they wouldn't listen to her, and she died, and the baby died. It was the most terrible thing. And to hear you say this, it clearly is a general issue. And how do we change the system so that people actually listen to black women and don't make stupid assumptions which cause damage to people and worse?
I think you just nailed it. People should stop making stupid assumptions. They're not based on any evidence.
I suppose the word I use is racist assumptions, but whatever. How do we get that to change?
I think we got to start off with just a level of compassion. I feel like that active listening piece, and look, we know that the NHS is really overstretched. We know that working on maternity wards can be absolutely crazy with the lack of staff and just so much work to do, so much workload. So we do have a level of empathy for health professionals working in the profession. But I think sometimes when you're really, really busy, that level of empathy can be lost, and you're just churning.
Is it about empathy? Because you'll be busy. You'll be treating white women. You'll be treating black women from a Caribbean background, or who lived here for generations, or really recently arrived from, say, Somalia. You'll be treating people from an Asian background. You'll be treating all sorts of people.
Yeah.
You'll be treating white women as well. They'll all be rushed.
Yeah.
So that doesn't mean that they don't say to white women, "Oh, you can't stand pain as much as a black woman, or your pelvis is a different shape, or whatever."
Yeah.
Is there something further back that needs to happen before they get on the busy ward and confronted with situations?
To your point, the state of maternity is bad for everyone, regardless of race. I feel like so many people, white women, are equally having really bad experiences, as well as black women. It's just that the stats for us tend to be a lot worse. So that we must also bear that in mind. But in terms of, I feel like there just needs to be a complete overhaul of the system, because so many things, for example, what things are being taught within the medical profession. So like what certain conditions look like on black skin, that is a real big issue that I know so many campaigners are trying to get to the forefront. So outside of maternity, but a relevant example I can give from my experience. I remember my son had hand, foot and mouth. There was an outbreak in his nursery, and they sent us a bunch of leaflets from the NHS and said, go on the NHS website and so you can check for what that looks like. And there were no images of black children. There was no evidence of what hand, foot and mouth looked like on black skin. So what exactly are the health professionals learning, black or white, is a very important issue. As well as data collection. So I'm a nerd.
What we're going to do, we're going to leave it at data collection, because there are other people coming in. But unless, Ben, you've got any more, I'm going to hand straight over to Sarah. Sarah, over to you.
Thank you very much, Chair, and thank you to everybody in the Health and Social Care Select Committee for allowing me to guest today. I am the chair of the Women and Equalities Select Committee now, which is also a cross-cutting committee, so I'm really grateful for these opportunities to guest. Thank you very much, Chair. And hello, Tinuke, again. This does feel like full circle. So I first met Tinuke when I was on the Health and Social Care Select Committee, and we were discussing some of the issues that we are still facing today. One of the policy approaches that we talked about 5 years ago was continuity of care, and how important that was to prevent some of the situations that Ben had talked about there and that you had expressed. Has that got any better, and is that still the kind of biggest policy approach that you would want to see, or is it the training side of things actually in maternity services?
I think it's a mixture of both. I feel like, again, we know that NHS is overstretched and midwives are leaving in their droves. So the actual model of continuity of care, I don't think it can, as it stands, I don't think that's actually entirely possible. I definitely think, in my experience, it would have been great in picking up the early signs of preeclampsia that I was showing midway through my pregnancy. If I had the same midwife the whole time, it would have been a lot different. I definitely agree with that, because I was seeing someone different every time. Maybe they're not looking at the notes. Maybe they're not checking. Well, not maybe. They didn't pick it up. So in that respect, continuity of care would have been absolutely incredible. But then, having said that, would we be here today if I didn't have that experience? I don't know. That's a separate issue. But yeah, I would definitely say continuity of care would play a huge part. And the training. Something needs to be done about the training.
And what about the diversity of the workforce? Because we did also talk about that, and how white midwifery tends to be, and particularly at a management level, that we are not seeing that diversity within the NHS structures. Particularly, this is causing a problem within maternity itself. Have you, from your work with 5 times more, seen an improvement in that, or have things taken a step back as midwives are leaving?
I'm not sure I'm able to entirely give judgment on, the workforce aspect, but one of our things that we always say within 5 times more is the fact that sometimes getting care from a black woman or a black midwife or a white midwife, it might not entirely make it, because you can make a difference, because you can get great experience from a white midwife and maybe not so much of a great experience from a black midwife, it's not a race thing as such. It's not that all white midwives are racist and all the black midwives are, angels, because people have had different experiences with midwives from different races. So I think it's a little bit dangerous to say, well, this is because, white midwives are racist. This is why this is happening. I think it comes down to the system and the training, because they're all learning from the same medical curriculum, aren't they? So if a white health professional doesn't know what things look like on black skin, maybe a black professional wouldn't, because they haven't actually physically been taught it.
And also the equipment that the NHS uses isn't always working with black skin, like pulsometers, for example. They work well on white skin, but not so well on black skin.
Yeah.
Thank you for that. When it comes to training, which you talked about, and awareness and systemic changes, I mean, that relies very much on the trusts themselves. And particularly, I know that 5 Times More had worked with some midwives and some training, but that is very much the agency of the people doing it. And so the best ones will continue to access that training, and the worst ones will probably continue to deny that they have a problem. Is there something that ministers could do to improve that situation for the ones that are less willing to learn, do you think?
I think it's to make some of this training mandatory. I think it's mandatory, and it has to be continued professional development in order for people to know what they're coming up against, but also what they can do in their own private practices to try and change that. It's not a one-time thing. It's not a one-and-done kind of situation, because this is something that, it's not just in maternity, it's all areas of health that we have to consider. There are inequalities when it comes to black people and people who, are in the ethnic minorities. So, yeah, I definitely feel like that could play a good part.
And then I just wanted to come, if I can, Chair.
Yes, you can. You've got till 10. You won't need it, but we'll carry on.
So the question I was going to ask is, there's diversity within diversity. And I have an example from Luton, which is very similar to what you had experienced all those years ago. And it is less than a year ago. She's a black hijabi woman, a victim of FGM. She gave birth in the corridor because she wasn't believed that she was in labour, even though she had told the midwives time and time again, I'm in labour, this was her 3rd baby. She knew what she was doing. She knew her body. She gave birth in the corridor. That was less than a year ago. She should have known on her notes that there was complications or potential complications, because she was a victim of female genital mutilation. Of the women that you work with, are there also different barriers for women that have experienced FGM, that are hijabi wearing, that are non-English speaking as well? Because I want to delve into the diversity within the diversity here, and perhaps some of the increasing barriers for different black women as well.
Mm-hmm. Yeah, no, definitely. Like you said, there's an intersection when it comes to black women. We don't all think the same, we don't all look the same. We have different backgrounds in terms of if we're black African, black Caribbean. Religion also could play a different part, whether we're 1st gen, 2nd gen. We literally are not a monolith, so you can't treat all black women the same way. I guess I could maybe talk about a little bit about pre-existing conditions, as you said, with like maybe FGM and that kind of thing. We don't delve specifically into that realm, but I've got some bits on pre-existing conditions that might be helpful. So in our current survey, we have taken a deeper look, the one that's going to come out in the next couple of months, into pre-existing conditions and the care plan or lack of care that women have been offered. And this is something we'll be highlighting in the report when it comes out, absolutely. From our last report, we collected data to see if people had pre-existing conditions and found that 1/3 of women reported not having any prior health conditions. 63% of women had a common health condition, and 31% of women stated that they had a medically serious or life-threatening condition. 31% of women had 2 or more conditions prior to pregnancy. So there definitely needs to be more done on pre-existing conditions. I'd like to read some quotes, if that's okay, maybe to highlight some of these numbers that we're seeing and kind of humanize those. During my second trimester, I had 2 episodes of pain caused by fibroids degeneration. It was raised with my GP and the maternity unit. On the second occasion, I was asked to go to the assessment centre where I thought they'd check the baby and release me with pain relief. I was admitted and spent weeks having follow-up scans until I eventually saw a consultant. Another one here says, I had an emergency C-section and I lost 3.3 litres of blood due to fibroids. The team had given me numerous blood transfusions and placed IV lines all over my body. Another one here, which is more around sickle cell, said I was fobbed off by the phlebotomist who refused to take my ethnicity from which my midwife had given me, as she said they didn't need it. As such, I was noted as white and my sickle cell test was not done. This was from a black woman. This example actually shows how a failure to follow protocol can cause, such as recording ethnicity down, can impact one's care. Another woman here said, I was informed that I had beta thalassemia. I was a beta thalassemia carrier after opting to be tested for sickle cell anemia because of my ethnic origin. The main focus was on making sure that my baby was not at risk, therefore my husband was checked. I had to push for further information about where this result came from and what impact it had on my baby. The midwife did not explain this to me. The care was satisfactory. However, they failed to to give me a genetic counsellor for my sickle cell trait. But it's not all bad though, and I do want to point this out. There are a few instances where conditions were managed properly and correctly from the outset. For example, one woman said, I had high blood pressure from the beginning of my pregnancy. I was monitored regularly. Towards my third trimester, I was monitored weekly. And another one said, I had diabetes in my first pregnancy and tested early on for this. I was also given extra scans as my pregnancy progressed. So what we don't want to scare women when we're out here and we're talking about black women's experiences, because it's not all bad, although we know the majority of women could probably relate to having a terrible experience, but it's not all bad. I have 2 experiences now, and one of them was not great and one of them was actually really, really good. And we know that good does exist and we want to highlight more of the good. What can we learn from that? How can we push for more of those things to happen?
Where is it?
Sarah, are you finished? Because
just one question, which is
great stuff.
Where are the good examples happening? Because I think we need to see where the good examples are, and we can push and say, why is this not being shared as best practice, and this is the standard that others should reach?
Absolutely. So just as a practical example, a few weeks ago it was the Black Maternal Health Awareness Week, which 5 times more run. And on one of the days, so we try to, again, highlight different intersections of different conditions and different things that can happen as black women. And again, so as not to just make it a really negative week talking about negative stories, we have some positive experiences that we highlighted over like 10 different experiences on our website and on our Instagram pages where people can learn from, and they do learn from. We have a reach of like literally hundreds of thousands of people that week, which is really amazing, and loads of health professionals follow us so they can see that black women are having great experiences and what that actually looks like. But I definitely think there needs to be more done on what is good practice and how can we take that further, because like I said, it's not all bad, but the focus on the good also needs to be there.
Thank you.
Thank you, Sarah. Can I bring in Josh, please? Thanks.
Yeah, thank you so much for sharing and bringing your expertise, and I'm sorry that you should have to be in a position where you've had to build up those expertise. I guess you were talking a bit about what good looks like, and Ben spoke briefly about the kind of, is it a training problem? Do you have a sense of the extent to which different ethnic groups are covered in training? Is that something that is specifically looked at in the midwifery training, or is it not? And if it is, to what extent is it? Is it, a module on on one Tuesday morning, or is it a proper part part of the midwifery course. Do you know that?
That's not something I can entirely answer. I guess speaking to student midwives, sometimes they tell us that it's not something, it might be just maybe like a one-off module or something. It's not like a one-off class or a seminar. It's not necessarily something that's embedded within the system. It seems to be like a throwaway if they do get anything to do with like difference in ethnicities and what to look out for, that kind of thing. So I don't think, but like Sarah mentioned, we have our training that we give to health professionals in hospitals, but that's a self-identifying thing. They have to, write in and say, we'd love to take this training. It's not mandatory, it's just something we offer. That's there. So it's not mandatory at all. And even the people attending, it's not mandatory for them to attend either. So again, it'll be, the people that are interested and want to learn and want to do better that will probably be attending that, but it's certainly not for everyone.
It's not kind of expected part of continued development or anything like that?
Not that I know of, no.
Yeah. Thank you.
Thanks, Josh. Can I hand over to Alex, who wanted to also ask a supplementary?
Thank you ever so much for your answers so far. I just wanted to come back to something you said in your initial remarks about feeling like you were kind of held captive almost in the hospital and not able to, until you had an intervention, not able to leave, and you felt pressured into making a decision. And I guess, so I've got an 18-month-old and we went through it fairly recently. And one of the things that we learned when we were doing all our research before was about, actually you have that agency, and lots of women don't realise when they're going into it, because it's such a scary moment. You've got so many things going through your mind and so many things happening in your body at the same time, that trying to advocate for yourself can be really difficult in those circumstances, in medical scenarios where you have professionals around you. But actually that women advocating for themselves is so important, and empowering them to do so. And I guess I wanted to find out from you, what could we be doing, or what could the government be doing to empower women to be able to better advocate for themselves in those scenarios? Because obviously we talked a lot about how the profession needs to listen more, but also how can we improve that advocacy so that we can make sure we're getting the right outcomes?
Well, you can work with us. On a serious note, though, we have our 5 recommended steps, which was our first ever resource, which essentially anyone can use, but we obviously are in the remit of working with black women, and essentially it's a few steps that you can for self-advocacy. I wish I had that the first time round, because I didn't. Just for context, when we actually launched 5 Times More officially, I was pregnant with my second child, and I was like, absolutely do not want this to happen to me again, so what can we do? Hence, that was our first resource. I think there definitely needs to be more done in terms of giving women that agency to be able to speak up for themselves. I wish this was happening in a few months' time, because we'd be able to give you some data from our report, our new report. But I know certainly from looking at some of the early stuff, that self-advocacy piece is starting to come through. But again, it's giving women that sense of agency to know what their rights are, that they can seek a second opinion, all of that kind of thing. This, I guess, maybe national campaigns may look quite, it might be something worth looking at, but getting the balance right, because we know what the stats are, and we don't want to continue talking about the stats. You've got to move forward into positive action, and maybe instead of saying, black women are likely to die, it's more of a, here's what you can do to stay safe from pregnancy. So that messaging also, I feel like, needs to be really right if you are going to go down that route.
Because I think one thing that I learned about it, and I was completely ignorant 2 years ago, if I'm perfectly honest, there is a question about you can do nothing, right? When people are offering you an intervention, you kind of assume that whatever's being offered you have to take. Yeah. But actually that option is available to say, well, what happens if we do nothing right now? Yeah. Can we do something, is this something that can wait for 2 hours, or does it have to happen in the next 30 minutes? Yeah. And I guess with all of the, is there in the studies that you've done so far, do you think there's a disproportionate impact on black women in terms of having that agency to be able to advocate for themselves? And if so, is there something particularly targeted that the government needs to do to improve on that?
I feel like, things such as white coat syndrome are very, very real. So, so many people are taught, well, a doctor knows best. The doctor's the one that's been through the training, so pretty much anything they say is a given. So it's about giving women the power back to say, you know your body better than anyone, and if you feel like this particular health professional isn't listening to you, you can ask for a second opinion, or you can escalate this, or you can ask more questions. Ultimately, we want more women to feel like they have all the information they can to make informed decisions, which unfortunately we're not seeing that at the moment.
Thank you.
Thank you. And just one question from me to Tinuke, because this is too close to home and I'm chairing this meeting because, for many reasons which I won't say now. But the question I'd like to ask, many women, black or white, but particularly black for this meeting, they live with things like fibroids, they live with things like, they're living with sickle cell trait, high blood pressure, diabetes, which they'll talk more about in the other panel. The problem I've had is many of these diagnoses are not even looked at when you're pregnant. So it seems to be that what you're living with, the conditions you're living with, when you're pregnant, they seem to ignore the conditions. Did you find that to be the case from the women you were talking to when you were doing your piece of research? And your experience when you were going through? No,
absolutely. I feel like that's more of talking about preconception as well. And we know that, I think I've got some data here from 2018, Public Health England. They found that 45% of pregnancies and 1/3 of births in England are unplanned, meaning that people are going into pregnancy without knowing a lot about their history, their family history, and that kind of thing. We were part of the former government's Maternity Disparities Task Force, and we're developing a pre-pregnancy guidance plan that aimed to enable women from ethnic minority communities to make informed decisions about their health and well-being prior to pregnancy, because that's really important. Some of these issues can become exacerbated or ignored whilst you are pregnant. I'd like to highlight maybe the case of Delissa Parks as an example, and I think this might have been what you were talking about, Ben, in that TV show. Basically, Delissa Parks she suffered from constipation really early, from an early age, and essentially her medical notes were not linked with her maternity notes. And her antenatal scans showed a displaced uterus, but it wasn't acted upon. And at 38 weeks, they had made a decision to manually turn her baby while she was pregnant because the baby was breech. And she experienced a lot of pain after this and went to the hospital in early stages of labour. She complained of being constipated, but she was sent home with suppositories. Again, they weren't looking at the actual issue that she was having. Unfortunately, Delissa ended up having an emergency C-section, but there was a fecal mass on her colon, which basically forced her womb out of shape. She suffered multiple heart attacks that day, and unfortunately, she died that night, and her daughter sustained brain injury, leaving her blind, deaf, and unable to walk. I feel like it's important, as health professionals and the government who are making some of these decisions, it's important to let women know the importance of talking to their family about their family and health history, because there needs to be an emphasis on talking about pre-existing conditions and current conditions, no matter how small they think it is or unrelated it is. Those issues can indeed become exacerbated when you are pregnant. So yes, I feel like there definitely needs to be more done in terms of women taking ownership of their health beforehand, but also health professionals realising what's going on as well.
Tinuke, can I thank you for coming today? And we are going to change the panel, and the second panel will get started. But thank you so much for your input this morning. It's been really informative.
Thank you so much.
Thank you.
Thank you.
Cool, I'll be back in 10.
All right. Thank you for coming this morning. And can we start with, I am hopeless with the pronunciation of names, but we will start with Sonah. Sonah. Okay.
Yeah.
So Sonah, can you introduce yourself to the committee, please, and we'll move down.
Yeah, my name is Sonah Paton. I'm a mother to 3. I've had 3 quite different maternal experiences. My first child was born quite small and quite poorly after I went in spontaneous labour at 28 weeks. My second baby or pregnancy was pretty clinically unremarkable, but it was full of times that I was very aware of my blackness. And my third baby, I found myself kind of leaning out of statutory services, and he was born at home, and it was lovely. My varying experiences inspired me to train as a doula and set up an organisation called Black Mothers Matter, which exists to support and celebrate black pregnancies.
Thank you for that, Sonah. Can we go to Professor Marian?
So, my name is Marian Knight. I'm Professor of Maternal and Child Population Health at the University of Oxford. I lead the Embrace UK inquiries, confidential inquiries into maternal deaths and morbidity. So, responsible, sadly, for the statistics that have brought us here.
Thank you. And
hi, I'm Shanthi Gunesekera. I'm the co-CEO of the charity Birthrights alongside Janaki Mahadevan. And Birthrights is the UK charity protecting and championing human rights through pregnancy and childbirth. We do that through information for women and birthing people, rights-based, unbiased information for women and birthing people. We provide training to healthcare professionals and civil society organisations. We act as a critical friend, we challenge trusts, we are prepared to use the law strategically to create change, we undertake research, policy influencing and campaigns, and you may be aware of our 2022 report into systemic racism, and this year we've also published a report looking at the state of home birth services in the UK and the disproportionate impact that is having on marginalised communities.
thank you for that. Can I go straight over to Andrew? Andrew, can you ask your question, please?
Sure. Well, first on the stats, so probably to you, Marian, if that's okay. I mean, we've obviously looked at the stats. We just heard that the statistics indicate that black women are 5 times more likely to suffer maternal death than other groups. But I mean, in just as a brief kind of opening remark in less than a minute, if you like, well, what are the highlights in terms of what does the data tell us about the differences? So
I guess I always want to start these things by reminding anybody listening, particularly black women listening, that maternal death is rare.
Exactly.
So it is really important that women are not going into pregnancy terrified, which is, where the work of Sonah and colleagues is crucial. There is about a 2.5 times higher maternal death rate now between black women and white women. So the black maternal death rate is about 28 per 100,000. For white women, it's around 12 per 100,000. I do see some green shoots. You've heard from Tinuke when she and Chloe set up their fantastic advocacy organisation. It was a 5-fold difference. So the difference has decreased, and the black maternal death rate has continued to come down very slightly. The difference is partly because there's been an increase in the maternal death rate amongst white women. So don't overinterpret the statistics. I think there's still a long way to go.
Yeah. I mean, just being, if you like, taking a heartless sort of devil's advocate. To what position? So don't misinterpret what I'm. So to what extent is that statistic explained by other factors? So if ethnic group A happen to be more deprived, have different kind of health comorbidities, etc., rather than ethnic group B, to what extent is that? Does that? I mean, obviously, if you go across the whole population, you take people into different groups. Not everyone is going to have the same, because one understands averages. So, I just wanted to kind of understand to what extent to what extent is it down to the can it only be explained by ethnicity, and to what extent can it be explained? Can it only be explained by, or can be explained by other factors?
So very valid question. Difficult to answer for maternal mortality because the numbers are relatively small. So doing that kind of adjustment is difficult with maternal mortality.
No, but not just maternal mortality, but also, for want of a better expression, the unsatisfactory outcome of the birth process.
So you anticipated the next bit of my sentence. We can look at maternal morbidity, severe complications in pregnancy. And when we look at that, deprivation or differences in deprivation explain only a small part of the difference between black women and white women. Complications, comorbidities, and you heard quite a lot about that from Tinuke, does explain some of the difference. So we do have to think very carefully about the pre-pregnancy care and how we can help with that.
Okay, and from your experience of talking to the profession, to what extent do you think it is a factor of benign ignorance or malignant discrimination?
So I am a researcher, and I've not had those conversations, and the work we do is based entirely on, we look at, in terms of the confidential inquiry, we have full copies of medical records of women who die. And there's a big difference between what is documented in a record compared to what may be exchanged verbally. However, we do see evidence of women's ethnic background being differentially referred to throughout. Again, Tinuke gave you an example of a woman not even being believed about her own ethnic background. And we see that in the documented records. We don't see evidence of malignant racism, but I wouldn't expect that to be documented.
No.
We do see examples of some of the misbeliefs that we heard from Tinuke.
Okay, yes, quite. And so to what extent can you pan this across to other health conditions? In other words, is the same disaggregation and difference in terms of both outcome and treatment, etc., the same with other health conditions? Being pregnant isn't a health condition. If you I don't want to get myself into deep water there, but so do you know what I mean? In other words, in other specialties, is that similarly a factor? Is that something which you have?
So I research entirely in the area of pregnancy and early childhood, so I can really only talk with any expertise around pregnancy and infant health. We know that there are inequalities in outcomes between different ethnic groups in other health conditions, but I guess I can't compare.
That's fine. No, so sorry. Two other quick questions. One is your communications with the health professionals, the Royal College of Midwives, NICE, others. This information has obviously been presented to them. What kind of response, reaction do you get from them? They obviously must be alarmed to think that this is going on.
So the Royal College of Obstetrics and Gynecologists, together with the Royal College of Midwives, have had a specific group focusing on ethnic minority women's health, so both black women and women from other ethnic minority backgrounds. I think that has now been disbanded, although they too clearly still recognise it as an important problem. I don't know about current activities ongoing in the Royal Colleges. My interactions are more with NHS England and colleagues at that level.
Oh, okay. And this may be an evaluation which may be beyond your analysis of statistics, but if it were white women who were experiencing these outcomes in comparison with black, do you think there would be a different sort of sense of urgency and action taken within the system to address the issue?
I'm pausing to answer that question because I think it depends which white women. Because we clearly see a big disparity between white women who live in deprived areas and white women who live in affluent areas. And have we got action to address that? I'm not sure we have.
Okay, thank you very much. That's very helpful. Thank you.
Thank you for that, Andrew. Can I go straight over to Becky, who wanted to ask some supplementary questions?
Thanks, Chair. So just one, actually, Marian, around the trend of your data. So you've talked about the fact that it's the numbers are coming down, which is great, but also the relative difference, as unfortunately maternal mortality for white women is going up. And I just wondered, have you modelled the trend of where you see the numbers going? So in other words, have you done any analysis that says in 5 years, 10 years' time, you expect it to have decreased by X%? And in that modelling, have you worked various different scenarios as to what might bring that trend down further?
Simple answer is no.
No. Okay.
I don't want to make excuses, but it is very difficult to do nuanced modelling with maternal mortality figures. And one of the things that you might let me say later is that I think we really need nuanced data on maternal morbidity, and we don't have it.
If it's okay, Chair, I mean, am I all right just to ask about nuanced modelling data?
Yeah, and then go on to your own question.
Fine. Right. So, Marian, please talk about that. It would be good to hear about the research that needs to be done still. That would be really helpful.
So, for example, we as Embrace, we have a responsibility for monitoring baby deaths as well as maternal deaths. Baby deaths, sadly, are more common, but that means that we've been able to develop what we describe as a real-time data monitoring tool. So every hospital has a live data viewer where they can see every death occurring in their hospital. They can see trends, they can look at different groups so that they've got a way of immediately responding to changes in the patterns, but also an immediate way to see the impact of any interventions, any changes they make, any training we've talked about. We don't have anything like that for maternal morbidity. That's what I would love to do, because then we've got a way of evaluating our actions. So the question earlier was, what does good look like? We don't know, because we often don't evaluate what we do because we've got no way of doing that easily and quickly. If we've got a data system, and we've got so many opportunities with data, we can evaluate what we can do. We can spread the good across the country.
And Marian, and I'll move on in a second, but why hasn't this data on maternal morbidity and mortality been collected already?
I think there's, understandably, do we want our staff to be spending time collecting data when they could be caring for patients? So I think we're now at a time of opportunity when our electronic systems are so advanced that we can do it without that additional staff burden. So I think it's a window of opportunity now to do it.
Right, that's really helpful, thank you. So, Sonah and Shanthi, I'd like to move on to talking about an issue that Tinuke raised in the first panel around the health of black women entering pregnancy compared to other ethnic groups. So thinking about pre-existing conditions, thinking about how the health of black women compares to other ethnic groups in the population. And once black women are pregnant with these pre-existing conditions, how well those health needs are met. So, Shanthi, start with you.
I completely agree that we need to have greater awareness of how different conditions manifest in different bodies, and that's a really clear finding from the Birthrights 2022 report, that you just don't receive training on how to recognise sepsis or jaundice in different bodies. However, I really want to emphasise that there is nothing wrong with our bodies as black and brown women and birthing people that can explain away the disparities that we're seeing in maternal outcomes and experiences. And there's a kind of very concerning meta-narrative going on around pregnancies and bodies being increasingly complex, clinically complex, and I think there has been evidence provided by Sue Down and others to show that the increasing rates of interventions aren't matched by the risk profile changing at the same rate. So I want us to be really cautious around this kind of angle of bodies and lifestyles being the problem. I think you will have seen from various sources of evidence that this is about racism in all its forms, and I think we also need to contextualise this within the fact that the maternity system is broken for everyone. You've seen so many reports into the state of maternity care in different hospitals and trusts, and women, whatever their background, are having a horrendous time for the most part. And what we can see at the heart of all of these inquiries and reports is that women are not being listened to. Their voices are not being listened to. The decisions they're making about their bodies and care are not being respected. Fundamentally, we have a right to decide what happens to our bodies and our care, and we have the right to be given unbiased information to be able to make that right, for that information to be accessible, and to not be coerced into practices. And when that system is bad for everyone, what we're seeing is it's disproportionately bad for black, brown, and other marginalised communities. And if we understand that the fundamental problem is about a misunderstanding of rights, like there is no understanding of rights from the front line to the regulatory services, right? Like that we have these rights is just not understood. Then the way the system is being designed isn't with our rights in mind. So it isn't enabling person-centered care. It's not enabling us to make informed decisions about our bodies and our care. And so when you've got this meta-narrative of clinically complex, increasing risk, the response is through that lens, and we're seeing more strict guidelines and pathways as to what needs to happen for different communities or demographic groups, which just instantly locks out whole communities from being able to make informed decisions about their care. It's if you come from this community, you're suddenly on this pathway. So, for example, in our recent home birth report, we're seeing black women being denied access to home birth services because of their ethnicity or demographic group, right? And so in these circumstances, we're seeing people are preferring to opt for unassisted birth, where there is no medical care or intervention, not out of an empowered decision to free birth, but because they feel like there is no other option, because the service is not listening to their voices, is not providing them with a safe space where they are getting personalised discussions about the risks that they're facing. And so within that context, and understanding that this is about racism, we need to understand that this is about racism, yes, at a relational level. Yes, there's huge issues with healthcare professionals, microaggressions, racist stereotyping, as Tinuke described, and not racism at a relational level, but they are also operating within a system where they are not enabled or empowered or supported to give person-centred care. And so the problems are also institutional, they're also systemic, and they're also structural, and therefore the solutions need to be at all of those levels. And it feels to me, from looking at the response of the different NHS trusts, but also of the NHS as a whole, I'm on the equity and equality steering group, I think, for the NHS, and the stakeholder council, that it almost feels easier for the NHS in the face of these huge, big problems to reach for the kind of cultural interventions, anti-racism training for staff and leadership, and clinical interventions and pathways. But I think we really need to be looking at it in terms of, if we're really wanting to affect meaningful change for Black, brown women and other marginalised communities, we need to be looking at structural levels. So at Birthrights, we're calling for new legislation. We think there should be a new Safe Maternity Care Act that makes clear how human rights and other law applies to maternity care, to make sure that everyone from the front line to the managers, commissioners, regulators understand and ensure that safety, accountability, freedom of choice and equity are at the heart of everything to do with maternity care. We need to end NHS charging, which is limiting access for women and birthing people, whether they would face charging or not, particularly marginalised, vulnerable women and birthing people. We need to be preventing the dismantling of core maternity services. You know, the government is talking about more NHS community-based care, and yet we're seeing the rolling back and the prevention of home birth and community-based services. And I think to this point of good practice that was talked about earlier, there are teams within the NHS or individuals who are really trying to provide person-centred care, and the institution is preventing that. And sorry, I know I'm talking, but I just want to
no, it's fine, and it's okay. What you're saying, no, absolutely, it's really valuable. So I'm going to bring in Sonah, and it's really interesting what you're saying, because I think, listening to you, I can hear I love the person-centred care, regardless of what you look like, where you're from, is absolutely the gold standard. And just when you were talking about other marginalised communities, I just wondered if you wanted to talk about socioeconomic disadvantage and, you know, where people are starting from in terms of their ability to access good nutrition, their ability to access good health services, because we know disproportionately more people from minority ethnic communities are socioeconomically disadvantaged. So I don't know if, Sonah, you wanted to talk about that at all.
Yeah, I guess from our work and our experience, there's quite a lot of anecdotal evidence that show, or that tells me, that often the response from healthcare professionals to some of those existing conditions looks really different for Black women than it does for others. Okay. So, for example, if a Black woman is starting her pregnancy journey and is diabetic or has a high BMI, I know that her midwife is much less likely to offer interventions around movement and good nutrition, and much more likely to rush to medication or more clinical intervention.
Why is that, Sonah?
You'd have to ask midwives. Okay. I mean, I have my suspicions. Okay. I have my suspicions, but I think that's probably a question for healthcare professionals. I think we see it in preeclampsia and measuring blood pressure. Quite often going into an NHS maternity environment can be quite a stressful time for a Black woman. So if her blood pressure is reading consistently higher when she's at appointments, having the I guess being able to look at that situation a bit more critically and maybe take that woman's blood pressure in a home environment or in the community where she feels a bit more at ease can make a massive difference to how her preeclampsia is recognised and managed throughout her pregnancy journey. And I feel like from my white friends and my white neighbours, those kind of that more softer first step kind of clinical care is offered much more frequently and encouragingly than it is to people within Black communities.
That's really interesting. And do you have any thoughts? I mean, Shanthi obviously has mentioned person-centred care, but do you have any thoughts about how we can bridge that inequity, that sort of clearly perhaps sort of a different style of approach based on the colour of your skin? Do you have any thoughts about how that might be improved or addressed?
I think having confident, honest, thoughtful conversations about the ways race and racism show up in all of their different dimensions across maternity care is probably the first step. Even in my own experiences, I remember my first connection with maternity was my booking appointment, which is typical, where you're typically weighed and height and your BMI worked out. BMI is flawed. I was told at the start of each of my pregnancies I was overweight. As a black woman, I feel quite confident that I'm not overweight. I also know that if I'm being told I'm underweight and BMI is the marker for that, there is probably a whole heap of black women that are underweight for black women that's not being flagged. And going through pregnancy underweight is very dangerous. So there's being able to think critically about all of these kind of touch points that happen that disproportionately negatively affect black women is the first thing that, one of the first things that needs to happen.
That's so helpful, Sonah. And BMI, I think, is an interesting discussion. And it comes up, obviously, with the National Child Measurement Programme as well. It's a really interesting discussion in terms of different body sizes. So thank you for bringing that up. Thank you, Chair.
Thank you, Becky. Can I go straight over to Greg? Greg,
yes,
over to you.
Thank you very much. And I want to focus in on antenatal care. So all the evidence that we've been provided in terms of written evidence suggests that black women are less likely to have adequate access to antenatal care. Why do you think that is, and what steps do you think providers of antenatal care should take to change this? Maybe Sonah first.
Again, just anecdotally, I think there was a lot of times in my antenatal care where I wasn't represented, or the information I was given wasn't particularly relevant, and actually it felt more relevant, or I could find more relevant or accurate information about me and my pregnancy outside of NHS provision. So by my third pregnancy, that's exactly what I did. So I imagine we kind of often talk about black women that are perhaps disengaged or not engaging with antenatal services. I think there's a lot of women that have followed that path, and either consciously or unconsciously, if the antenatal provision is not relevant, doesn't feel safe, will not engage with it. Something as small as being able to see a black baby in utero is a real novel thing. It's something we use as standard in all of our provision because we're catering for black mothers. But actually, if you're a midwife and you're trying to engage someone in talking about their pregnancy, and all of the literature and information you have is of white bodies and white babies, that's quite it's just quite hard. It doesn't feel relevant, and there is other information elsewhere. So I think that is part of it. And I also think, going back to all of those kind of, I guess, softer or subtle moments when people are made very aware of their blackness, like I just described in that booking appointment, these add up or kind of tot up as you go along your maternity journey, and as you come to the end of it, and your exposure to your midwife, your care team becomes more frequent, and those exposures become more frequent, it can feel a lot safer to disengage and protect yourself.
I think that's helpful, thank you, and very powerful about sort of once someone's accessed antenatal care, the problems there. I suppose what I'm trying to focus in on is why, according to the evidence that we've received, black women are less likely to have adequate access at the start, and therefore access antenatal care later in sort of in the, I don't know, Shanthi.
Yeah, I mean, the question is, why are people not wanting to engage with it, which is kind of, we understand the provision of maternity care not just from our own personal experiences, but that from our communities and from the news. And I think there's a real issue of trust around safety and being listened to, and we've seen, when people do not attend antenatal services, we've seen hospital policies requiring referral to social care or the police, despite that being within your rights to not access antenatal care or to decline medical intervention. And equally, when people do access antenatal care and make informed decisions about their bodies and their care, perfectly lawful decisions, we again see a consistent number of people approaching us being referred to social services or the police for those decisions. So that is like a small example of showing how the system is not demonstrating it as a place of safety and trust for communities to access, alongside, I mentioned earlier, NHS charging and anxieties around that, and a misunderstanding around gatekeeping or fear of costs, particularly.
I don't ever put in, but I need to ask you a question. If people are engaging and social services are called, is that all communities or just the Black and Asian community?
I don't have data, but I would strongly... the policy is there for anyone not accessing antenatal care, so we're working with a trust at the moment on their policy. I would suspect you would see that policy being enacted more for particular communities, but that's conjecture on my part.
I suppose what we're trying to get to here is we as a committee presumably want to make some kind of recommendations to improve, for the questions I'm asking around access to antenatal care, and making sure that, again, according to the evidence, that Black women come up to at least the average of access. What I'm trying to get to is what steps should we be recommending to providers, and indeed the NHS as a whole, and social services. What should we be recommending to improve this? I'll go to Professor Knight, and then I'll go.
So we need to think about a lifelong approach. So what we've heard very clearly from everybody is how what your experiences before you get pregnant influence your access to pregnancy care. And we also have to recognise where trust is lost and where trust already exists. And we also have to recognise that the system as it's designed at the moment, and my interpretation of later booking is that the system we have at the moment is not working in a personalised way for all women. Why are we not thinking more about community models of antenatal care where Black women can be accessing the care they need in the community with people that they trust, with a continuity model of a trusted person? It may or may not be the midwife. It may be a doula. It may be another trained professional from their community. So I think we do need to think more inventively about our models to make them work for the groups of women they're clearly not working for at the moment. And we need to evaluate what we do so that we know what's working and we can spread it.
That's very helpful. Thank you.
I was going to build on that. Sorry. I was going to say, no, I feel like we have a great example of good practice or best practice in Bristol. So Black Mothers Matter, we have a pregnancy group that is funded, or we receive funding for a 1-year pilot from our local NHS trust, and that was open to anyone at any gestation up until the time they gave birth. Engagement was really high. People engaged with us from as soon as they got a positive pregnancy test. They're able to connect in with us on a regular basis. All of the sessions have a NHS midwife present as well, but they don't lead the group, but they are available to. We can provide continuity of care. We can talk about a range of topics that impact pregnancy. That could be housing, relationships, nutrition, exercise, and support people or facilitate people in engaging in NHS antenatal care, but via the community, because we have that trust and we have that understanding, and we can talk about the specifics of navigating the system as a Black person, or potential responses when the obstetrician inevitably says, I think you should be induced. Conversations like this that actually can't happen in classic midwife appointments or antenatal provision can happen really well and really richly in the community with support from statutory services. And I think that's a model that works really well, and just from the pilot in Bristol has been life-saving.
That's really interesting. With your permission, Chair, I think we'd like to see, any evidence you've got on that. Would be really helpful, because obviously we're looking for examples of best practice, so that's really helpful. Yes, Shanthi.
Could I just add that there's so many examples of community-led support, which I think is really important, but it cannot detract from the kind of dismantling of NHS community provision as well. It needs to go hand in hand. So what we're seeing is community-led or community-based maternity units, midwife-led units being withdrawn or dismantled, and the two need to go hand in hand.
Thank you. Thank you very much, Chair.
Right, thank you for that, Greg. Excellent. Alex, can I hand over to you? Thank you.
Thank you, Chair. Actually, just to follow up on that first before I go into my questions I meant to be asking. So we heard last week in a separate evidence session about family hubs, about perhaps the importance of having more of the antenatal checks in those family hubs, and how, Sonah, do you think that pilot that's in Bristol, which sounds really interesting, do you think that model could work in a family hub in terms of taking that pilot out to the network of family hubs so that they're out in every community?
I think in theory, yes. I guess building on what Shanthi said, as long there needs to be proper investment. So like I said, we were funded for a 1-year pilot, but within our Black Mothers Matter team, we have ex-midwives, we have people that are really skilled in kind of navigating NHS systems, and we have the support of our local trust, which actually is the support of 2 individuals that are really committed to improving black maternal health in the Southwest. And those are some really key factors in making that successful. And I think, like Shanthi said, there's sometimes when we look at community-based solutions, there's an assumption that those are cheaper or not of the same quality as statutory services. As long as that approach is not taken, I think it's a fantastic potential model that could have really big influence as long as it's invested in properly. Yeah.
Great. And Shanthi, we talked briefly about the report, and I'm sure lots of your answers already have kind of drawn from that 2022 report, but just in like a minute, and I know that's really difficult to do, could you kind of summarise kind of the key findings of that report in relation to the...
Yes, so nature of racism, individual interactions, so being ignored and disbelieved, racist stereotypes, microaggressions, dehumanisation, denial of pain relief, which you've heard from Tinuke, education and training, so white bodies as the norm or default, failure to recognise conditions such as jaundice and sepsis, lack of cultural understanding, policies and frameworks, ethnicity as at grounds for induction within policies, high-risk pathways based on ethnicity alone, lack of representation in clinical evidence and committees, NHS charging regime and failure to provide interpreting services, and workforce lack of senior representation, higher rates of disciplinary action, bullying and toxic culture.
Yeah. And that's all under the banner of systemic racism.
Yeah, I mean, I think that covers relational, systemic, institutional. Yeah.
Okay. And obviously that report was in 2022. Has there been any progress in addressing those issues since that report?
I mean, I think from the report we've just done into the state of home birth services in the UK and the impact that is having on marginalised communities, we're seeing, I don't feel positive about progress. I feel, women and birthing people from marginalised communities are still feeling like their voices are not heard, their decisions are not respected.
And so I just want to come back to something you said in the and you don't have to answer this question if you don't feel comfortable, but you said you have your suspicions about why things haven't happened. Does that align with kind of what Shanthi just said? Do you think that might be part of the issue?
I can't remember what I had my suspicions over. I'm a suspicious person.
I think it was about the differences in how people had been treated, and you had your suspicions, and you referred it back to medical professionals as to why they might deal with certain groups differently. In terms of, I think it was about Becky's question about kind of pre-existing conditions, and diabetes, I think was the example you gave. I guess my question is, and feel free, you don't have to answer this question, but you said I'd be very keen to hear what your suspicions are, because obviously you've done a lot of work in this space.
I guess my overall suspicion, or I get lots of signals that female bodies, black and brown female bodies continue to be undervalued or of less value to lots of people that have power and the ability to make change and decisions, and that's a suspicion I have, and I think the current state is a bit of a reflection of that.
Shanthi, you want to comment on that? Yeah, of course.
That I think if you look at, for example, clinical negligence claims within the NHS, I think 40% of that is accounted for from maternity care, and that's the cost to the NHS of the systemic failure in maternity care is huge, and it is sort of leading to a kind of defensive risk avoidance approach by hospitals and trusts. In many cases, I think you have the kind of legal teams are almost setting the policy, the clinical, policies about who can access what. And so I think when you've got that kind of risk-averse defensive position without an understanding that actually the best way to save care is women and birthing people having a voice, decisions about their bodies and their care, and that is going to be safest both for the person who is giving birth as well as the healthcare professional providing that support. At the moment, that's not understood, and so you're seeing a risk-based approach where you've got blanket policies in place, and I think that contributes to why some healthcare professionals may respond to the most extreme response in certain scenarios.
Oh, and Sonah, we've also talked about the pilot you've run in Bristol. Are you aware of any other kind of policy initiatives or programmes that are out there that are enabling communities to provide culturally competent care?
I'm biased because I founded Black Mothers Matter, but I do think we have built a fantastic model of care. I feel like in Bristol and the Southwest, and it's not just our community model of care, but that being supported by local authority and NHS, and building a much more connected picture of maternity where everyone is included and considered, makes a massive difference in outcomes and experiences for those most at risk.
I guess just opening up that question to the rest of the panel, is anyone else aware of kind of particular areas?
There are definitely other models, so the Lambeth Early Action Partnership is an example that they've recently evaluated. Improvements in child development, maternal mental health, in fact parental mental health, so paternal mental health as well. So there are definitely models. The challenge often is you've got 1 year of funding. How can you evaluate the impact in 1 year? It's really difficult.
It's hard to deliver systemic change.
Exactly.
Yeah, and I think as well finding funding to fund joy and creativity in Black maternity is really important, and I know is so impactful on improving experiences and outcomes for Black women. But finding a funder to commit to that is a real challenge.
It's a measurement issue.
Right, thank you for that. Oh, sorry, Alex.
Move on to my next set of questions.
Oh, right, sorry, I thought you'd done them.
On continuity of care. Yeah. Okay, quickly.
Just a minute, Alex. You wanted to ask a supplementary then.
I used to be on the Integrated Care Board for North West London, and I spent a long time trying to get them to recognise structural racism as an issue. They did, and they've instituted a programme. I don't know how much difference it's had, but this partly came out of COVID, and lots of Black people didn't want to be vaccinated because they didn't trust the NHS, crudely. If you had worse treatment, worse access and worse outcomes, it's understandable. But it was a real issue in getting people in the NHS anywhere, particularly white people, to talk about structural racism, because I think you're accusing them of racism. Well, you're not. The system, however, can be biased against you, and it is structured, and there are huge issues. How much do you think the NHS as a whole recognises structural racism as an issue that needs to be addressed? I'll start with you, Shanthi.
I mean, I would say there's recognition of the need to address racism. I don't know if there's understanding of what that means.
Yeah.
And so that's at a kind of NHS level. And then, our experience echoes yours when we're delivering training. There's a kind of recognition that racism might exist, but not here.
I guess from my experience, people feel so wildly uncomfortable often even saying black woman or race or racism, which is a signal that they're not comfortable to have those conversations. I, again, have seen great work and change in Bristol. There's a programme called Black Maternity Matters, which is a long and deep anti-racist programme that supports healthcare professionals and senior leaders in developing those competencies and confidences in talking about race and addressing the systemic issues. And I truly believe if we can get that programme to enough people and we get to work out what the tipping point is, there will be a culture shift, and that's how that will be really impactful in the way NHS organisations in Bristol in the southwest are able to talk about race and to tackle issues of racism.
I don't think we think in the NHS that the structure we provide, we don't think about it in that way. We don't think that it's not providing. If it's a system that doesn't provide the care for particular groups of women in the way they need it, we don't think about it as structural racism.
You don't really think about it. I mean, forgive me, Chair, they don't measure, and there's no proper ethnicity measurement, operations that people go into. We're not just talking about maternal health. It's the lack. When Penny Dash came to see us, she talked very encouragingly about improving data in the NHS, but ethnicity data, and talking to people and listening to them, these things. There's there's a great opportunity to improve that.
So while we're on data, we need to have women's experiences as part of the data, because that's how we will then clearly show that what we're providing is not what women need.
Women's experiences and ethnicity data, yes?
Sorry.
Ben. And we go back to Alex now. Thank you for your answer. Alex, back over to you.
Thank you.
To finish your point.
So my next question is on continuity of care. So we touched upon it in the first session, and from my own experience of it, we were really lucky. Our community midwife was the same throughout, and she ended up being on call on the day of delivery, and so she was actually a delivering midwife. And having spoken to a lot of people and parents since, that experience is incredibly rare. I guess quite a generic but wide-ranging question here, but what can be done to improve the continuity of care that women, and particularly black women, receive throughout their pregnancy?
I agree that there's lots of evidence that shows the impact continuity of care can have, particularly for black and brown women and birthing people. But our 2022 report also showed that there's limitations to that within the existing system, right? Whilst racism is so prevalent, whilst you've got so little culture or support for person-centred care, then you could end up with a continuity with someone who isn't the right person for you. And whilst you have the right to ask for a change of care, that I know from my own experience that will feel really awkward to do that, even if you don't have to provide a reason. So I think it's a really important ambition, but we need to recognise it's not the solution on its own. It needs to sit alongside a wider set of issues. And I just want to make a small point on related to what Ben was saying around data, that we also, when looking at ethnicity data, particularly around if trusts aren't aware of it, they have autonomy to decide on the patient safety incident response framework. They have autonomy to decide which patient safety incidents to investigate, and may not investigate ones based on ethnicity, so we may get a skewing of the data there. And on Marian's point, it's really important that we're not just looking at clinical outcomes. What could be clinically good could still be a really horrendous experience for someone and have long-term psychological impact as well.
Just on that data point, obviously we know in 2022, the NHS England took out the kind of the target date for that continuity of care piece because of the staffing levels and the ability within the system to actually provide it. Is that impacting our ability to understand kind of the impact that it's having and the data we're able to collect around continuity of care?
I guess I don't have an answer to that. I don't know that we've got good staffing data on continuity of carer. I guess the point I was wanting to make is that the evidence is that there are lots of different models of continuity of carer. It doesn't have to be a midwife, and actually some of what you're providing is providing effectively that continuity of carer. So we could be thinking about different models of that single trusted relationship to help navigate, help advocate. And again, maybe we need to be thinking more broadly than continuity of midwife care, as you quite clearly point out. It can work. You had a fantastic example, and sometimes it doesn't. But also, I just wanted to make sure that we're handing over. So there's often a huge gulf postnatally. We don't have health visitors in the way we used to. So even when we've got continuity for some part of the maternity pathway, it then might disappear. So we've got to make sure that it's also handing over of that care.
I guess just picking up on that point that Marian made, do you think there's perhaps not enough focus on the role that doulas can play and others in providing that continuity of care?
Yeah, I definitely think there's some ways that we could think creatively about filling those gaps and providing continuity of care, and actually that a solid, fantastic relationship can come from a whole load of different people. And actually I know quite often the women we speak to, they don't distinguish between the different types of healthcare professionals that are involved in their maternity journey. They couldn't tell you the difference between a midwife, an obstetrician and a health visitor. They're just part of that team. So I think, consistency, and like Marian said, postnatally as well, could have great impact.
Fantastic, thank you.
Thank you, Alex. Could I just ask one question? You've all talked about continuity of care, and everything in my head keeps saying individualised care. What I don't hear is that the person is treated as an individual. When did we lose that in the maternity system?
You've probably known something. I'm not sure I have an answer to that. The model as we have it at the moment is designed. Yeah, it's designed as the staff want to deliver it rather than with the woman at the centre, and I mean that's why having women's voices embedded in any service change, designing service change has to be essential for that. I guess we've gone post-pregnancy. I just want to come back to pre-pregnancy, and that's where we really need to start the individualised care, because we could help women so much before pregnancy to prepare for pregnancy, to get the medications right. You were talking about diabetes at the beginning. So that women are empowered from before pregnancy, from school, to be able to know what they need as an individual. Having to advocate for individualised care is obviously not an ideal place to be, but as a minimum that at least then helps women know what they should be being provided with.
Right, I'll let you answer, Shanthi, and then I'll hand straight over to Jen. Shanthi.
Just a quick addition, I guess we need to recognise the foundations of the NHS. I'm not sure when did we lose individualised care is the right question, because
what do you think is the right question?
So much of it is founded on a kind of colonialist, racist, patriarchal approach. Like that's the kind of history of maternity care, right? So I think we need to recognise that, but I would say that probably COVID exacerbated the sense that the NHS can implement blanket policies and get away with it.
Excellent. Can I hand straight over to Jen, please?
Thank you, Chair. So I'm quite interested, following along a lot of the discussions about one of the key issues that black women face is this sense of almost a reluctance to access sort of NHS services because you feel it's not a space where it's not a safe place to be, it's not the place where you'll get the treatment that you need. I do wonder if in the field of mental health support, particularly postnatal mental health support, if that is particularly acute in that area, given the almost double hurdle of if you're having a mental health crisis or you're experiencing poor mental health, you might even, those feelings might be exacerbated. I wonder if maybe, Sonah, you might like to talk to that a bit.
Yeah, I think where we see huge and often, like I said, life-saving impact is postnatally and creating places and spaces where black women can talk more freely about mental health and struggles, and also it's normalised and becomes just a part of their like we talk a lot about physical recovery from pregnancy or from giving birth, but also the mental recovery as well, and having just regular places, spaces, times where that is part of, planned in, and the scheduled part of your recovery is really important for black women for lots of reasons. Black women do not present with mental health issues in the same way that white women might. For lots of reasons, they'll present later to healthcare professionals where things are much more extreme or severe or require much heavier kind of clinical interventions. And lots of the, I guess that the like softer, lighter, I'm not sure if those are the right words, interventions offered by NHS, like talking therapies or vitamins, just don't really feel fit for purpose for anyone that isn't kind of white and middle class. And for that reason, yeah, having places and spaces where black women can focus on mental health is critical. Yeah.
That's really interesting, because I noticed that black women are much more likely to be admitted to inpatient treatment for postnatal maternal care, but also much less likely to access and receive initial mental health treatment. So do you think there is a systematic thing happening where black women are unable to receive the right treatment at the right time when it comes to postnatal mental health care?
Yeah, and I think there's a real risk for black women being honest and vulnerable with their mental health that is different to white women. So we've talked about the social services and police being involved in, especially postnatally or after just having a baby. Again, I don't have data, but anecdotally that feels like it comes a lot quicker and a lot heavier for people in our community that express mental health concerns than it does for other women. And of course, if you have a neighbour or a friend or a cousin that was in mental health distress, called someone for help, someone their midwife had said call for help, and ended up with their kids being removed or placed somewhere else temporarily, or ended up being restrained, the kind of collective knowledge on mental health support amongst the black community is that it's not safe, and to kind of stay away and to find other ways to deal with that.
Is there a training issue with NHS clinical staff when it comes to mental health support, or is there more of a solution in finding those sort of community-based interventions, because that trust is so far removed that actually trying to just train people to recognise different presenting mental health conditions or late presenting mental health conditions is not actually sufficient?
I think it has to be both. I don't think there's not one solution that will fix it. I think it has to be both and invested in from both sides.
I think, Shanthi, you might be able to speak to this a bit. What kind of incentives could be built into the system to encourage both clinical staff and maybe community-based approach to recognise the unique challenges that black women face with their postnatal mental health?
I don't know if I can answer that. I think this is part of just the general decolonising of the training curriculum, and not seeing white bodies or white as the normative. And I think it's also, I think there's loads of really, really good community-led support out there, and it's just thinking through how to support those community-led structures that are in place as well.
Thank you. And Marian, looking at the data, are there any gaps in understanding sort of the drivers between black maternal mental health either being picked up too late or not being treated appropriately? And are there any gaps in the data as to how that drives postnatal mortality?
So, in terms of postnatal mortality, we've got clear data on that, but again, because the numbers are small, I can't show a statistical difference between black women and white women. I think we've got to recognise that we're talking about perinatal mental health services. There's still we still have a long way to go before we've got enough perinatal mental health services, and often women have to access community mental health teams who don't have perinatal expertise, won't recognise how quickly women's mental health can deteriorate in the perinatal period, definitely won't recognise different patterns of distress, for example. So I think we have to recognise that there's a long way to go in terms of getting to a stage of ideal postnatal mental health care, and this is black women or white women. I think there's, and I'd be interested in Sonah's perspectives, but I think in some communities the amount of stigma, I mean, there's a huge amount of stigma around mental health conditions already, and I think it's even greater. And so when you're also fearful of social services involvement, the enabling women, and it speaks back to the trusted relationship, somebody with whom they can actually express the distress they're feeling in a way that is understood, listened to and acted on, is what we really need. I don't know whether you've got anything in terms of thinking about stigma.
No, just that it exists for, not for all black communities, but it does exist, and there's definitely a kind of generational pressure, or difference in understanding of mental health, and that can be quite hard to navigate, depending on if you're, first or second generation in this country, and having conversations with, quite often black women don't have the family support to talk about mental health, because it is understood so differently between generations if there's been kind of quite recent migration. So just kind of all of these things build just quite a slightly different picture of perinatal mental health for black women that isn't often picked up or considered by mainstream services.
It's a case of having something that's more bespoke, almost recognising that black women's experience postnatally is, especially in the field of mental health, that there are a number of different things interplaying. Would you say something along those lines, actually people having that, I'm trying to think, almost having that awareness and that acknowledgement that there will be a whole set of different reasons, either cultural stigma, the experience that people have had to date with maternal services in general, awareness of, past bad treatment and being a neighbour or a friend or a cousin having an awful experience. Is it enough for people to start to acknowledge that, or does something sort of bespoke as to how that's handled for going forward need to be developed?
I'd say, again, a mix of both. There's not one approach that will work for all, but I think a mixed approach is really important. And I think like recently everyone's become like really trauma informed, and that kind of, there's trauma informed practice seems to go into everything we do, and the way we consider lots of our healthcare and social care. I guess I would like to see the same for kind of race informed or racially informed. It's not necessarily a specific service or offering. It's the way that business is done. It's the way that services are provided, in the same way that they're moving to be more trauma informed, that they're also racially informed.
Thank you so much. I could talk about this all day, but I'm going to go back to the chair.
Then I am going to move swiftly on. Over to yourself, Josh.
Thank you very much. So, firstly, obviously, in 2022, we had the Maternal Disparities Task Force. I mean, by the looks of things, there hasn't been much movement. What do you think the main blockages to movements in that are? I'm going to start with Shanthi.
I think, what do I think? That the issue is really big, and like I said, it's on multiple levels. I think in terms of structural, systemic, institutional and relational, and therefore if you're only trying to tackle it through one of those lenses, you're never going to solve the whole problem. Alongside that, I'm not sure I fully understand, and you probably understand much better than I do, but the level of teeth that national bodies have with local trusts. I think that also plays a factor in terms of what is expected from local trusts, and the autonomy that they're given can mean that this kind of idea of, racism exists, but not here. That's going to be embedded throughout everywhere. So, sorry, that was quite a short answer compared to my previous answers.
So I guess I'm kind of thinking, my instinct is almost like looking at the other shifts that are going on in the NHS. What could we do to tie them in with the work that clearly needs to be done in this area? And obviously, the final example we were given by the last speaker was one of those where the notes weren't integrated, and that there were racial elements, but there's also just basic incompetence, and that's why we've got this idea to digital shift. But obviously the two kind of care related shifts are hospital to community.
Hospital
to community.
Hospital, sorry, and sickness to prevention, or kind of, obviously sickness isn't quite relevant with maternity services because it's not being sick, it's it's medical event but it's things going wrong. And I kind of wonder if there's an opportunity here to be grasped if we're saying we need to move from hospital to community, and I think the more medicalised births seem to be informed by more trauma from what Sonah was saying, and I wonder and the kind of also moving that to community and also looking at prevention, and feel like there's an opportunity there. I wonder if Sonah, you could talk a bit about that, kind of what we can do to work more towards prevention, and how we can use perhaps some of the skills that you've developed in Bristol and some of the examples there.
I think maintaining or starting investment and maintaining interest in the topic. It feels like, as someone in a kind of grassroots movement, it feels like the topic can be picked up and something's going to happen, and then something else comes in and distracts it. Whereas the reality for me in my community is this is what we're really living, and actually for us and our organisational successful impacts, lots of those have been attributed to or have been made possible by key individuals in places of power that have really maintained an interest in this topic and are determined to keep changing. So I don't think there's any quick solution that will solve it all, but I think a continuous trying and investment in development will make a difference. I think some more joined up working between community and community organisations, people in the community, NHS organisations, local authority will be really helpful as well.
I think maybe that's something that we need to look at in terms of recommendations, in terms of making sure that we're doing that with the shift.
Yeah.
You've got your hand up.
Marian, you go first.
I was going to say, I think we can capture exactly what we need in those 3 shifts. You know, the sickness to prevention. If we've got good pre-pregnancy care for women who've got pre-existing conditions, you know, we can work with those women to optimise their health during pregnancy, which will prevent pregnancy complications. The analogue to digital, there is so much more we could do to help with personalised care, but also to you know, we're doing some research around using data for an early warning system. So again, helping to hear women's voices and prevent complications, of which infection is one of the leading ones. And then the hospital to community, so much more we could do with community continuity of care type models. You're probably going to say
well, I was going to add that they're really great ambitions, but is just so devoid from the reality of what is already happening that it's almost the point that the plans will come in place to implement those ambitions. Things will have gone so far back that it's almost impossible. So you have this idea of a hospital to community, and yet, you know, within the last 3 months, midwife-led units or whole maternity units are closing in localities, right? Because they have deemed that the local population, the local demographic is too high risk for needing these services. And it's so short-sighted because that's based, or there's not enough take-up, but that's based on like these really blanket policies that are in place where certain people aren't offered options, so they're already taken down the high-risk pathway without individualised care. So, you know, that's you're starting from a point where you're not going to be able to get to that place unless you halt and reverse that dismantling now. And in terms of prevention, I just would iterate and reiterate the importance of understanding rights-based care and the importance of respecting our right to make decisions about our bodies and our care. And that is just not, I mean, if that is understood, it could unlock a lot of other issues within the services.
I think it's so key in maternity care as well, because it's one of those areas where people are most vulnerable, where being empowered is a real opportunity. Just going to quickly move on very quickly, Professor Knight, to how well do you think that the government are evaluating the impact of what they've done so far, and how can they do it a bit better?
I started with this point. There's a real limit to what we can. We need to evaluate what we do because we need to capture the good and scale it up. And there's a real limit to what we can do by solely monitoring maternal mortality. We have to monitor maternal morbidity and the severe complications and women's experience, and only then will we have the data about what works, and therefore then we can, and we'll know it much more quickly as well, because there are many more women who have complications. Every woman has an experience, and that will allow us to move much more quickly.
Thank you. I'm going to let my colleague ask some questions.
Thank you. Sarah has a couple of supplementary questions. Yeah. Sarah, over to you. Thank you.
I do have quite a quick one, so I'm going to ask individuals to answer them, if that's okay. On the agency that black women have around what type of birth they want, I think we've heard a lot about how women are trying to advocate for less medicalised births, but I think it's really important there will be some women that will choose, like myself, to have a C-section. I was afforded all the privileges of being able to speak the language, being able to advocate for myself, but I still had to fight for that. How are we ensuring that black women and other marginalised minorities are actually being heard when they say, I want more medical intervention and I want to have a different kind of birth?
I think that responsibility lies with the workforce. Like, we can, as an organisation, with the work Chloe and Tinuke do, through the work we do, Birthrights give black women all of the tools to advocate for themselves, give them all of the knowledge. But ultimately, when they show up at a hospital, like, it's up to that healthcare professional has such a big plays such a big part in that experience. Like, for me as a black woman, if I speak up or speak loudly, that is very often misconstrued as me being aggressive. And there's so many. There was a case of a lady in Liverpool, and she unfortunately died. Her medical notes were shared, and you could see where she was clearly trying to advocate for herself, and I knew that because from reading her notes as a black woman, but where she was described as aggressive or, a bit difficult and things like that. So that, I guess, that burden of allowing black women to advocate for themselves lies within the NHS and those systems and structures.
Marian, we've talked and we've heard from Shanthi and from Sonah about how we need to have a much more joined up between the community, between health visitors, between maternity services as a whole. With the 3-year delivery plan for maternity and neonatal services and all the government initiatives, how big an impact is the workforce? Because we know that from the Royal College of Midwives are doing 100,000 hours a week of overtime unpaid. This is leaving the idea of training, let alone person-centred care, as a complete unicorn for many midwives and maternity services that really want to be able to do it. So how important is that we get that part of the workforce as is right? And with health visitors, there's a huge disparity between England, Wales and Scotland. So continuity of care for health visitors in England is just 45%. In Wales it's 85% and in Scotland it's 90%. How are we going to see standardisations along there, Marian?
I'm not sure I'm the right person to talk about workforce. What I can say when we look at the care of the women who died, we see clear evidence of deaths that have been women that have died where there have been clear workforce pressures. So, for example, simultaneous emergencies, and they've not been able to undergo a caesarean section at the timing that they need, for example. So that evidence is clear. I do think we could think more creatively about where we, some task shifting. There are, I think, lots of tasks that we don't necessarily need our midwives or indeed our doctors to be doing, and we should think about who could do, what other parts of the workforce could do that to help free up some of that time for midwives to have these trusted relationships that women clearly need. I'm not saying that we don't need more midwives. I think we clearly do need more midwives, and that evidence is very strong.
Thank you, Marian. Shanthi, this last one is for you. You've talked about how, and I think you've answered questions from Ben and from Andrew and from Alex about the reluctance to accept that there is racism within an NHS trust, that it's happening outside, that there is racism and that it's systemic racism, but they don't really fully understand it or see it in themselves. I'm going to give you a really clear example. My hospital in Luton, the Luton and Dunstable Hospital, they had a CQC inspection last year, and that report came back as having racism for staff and for patients, clearly racism, and that's really strongly put in that CQC report within maternity services. What onus is there on that NHS trust to do better, to actually reach out to people like Sonah, Tinuke, and 5 times more? And what can trusts that are clearly being evaluated as underperforming and, in this case, as racist, what can they do to do better, to improve? Is there a standard way forward, or does there need to be a standardisation in how to progress out of that poor level of service?
I mean, yeah, that's a huge question, and I guess obviously there's a responsibility on the trust to change in terms of providing services to the communities they serve, but also a legal obligation in terms of direct and indirect discrimination. I think we know that there's lots of healthcare professionals who want to provide person-centred care and provide rights-based care, but they're not operating within a workforce culture that enables that, often toxic, bullying culture. So there is a real issue around leadership in some of these trusts, and I guess bringing a rights-based lens to it. The training we provide to healthcare professionals is always delivered by someone with a legal background, often a practicing lawyer, and someone with a healthcare background, often a practicing midwife. And what they really emphasise through the training is providing rights-based care doesn't take any more time, right? But it's just about the culture that sits around that. I think there is an onus to look at throughout all of a trust's approach to how they provide care, what their policies are, how they support out-of-guidelines care to enable person-centred care, and how they support staff to provide individualised care. And within that sits then ensuring that the staff and the trust as a whole are providing culturally competent care and understand how racism is showing up in their trust. But we also cannot continue to push the onus always on the healthcare professionals or indeed the trusts when there are these wider systemic and structural issues that are influencing that as well.
Thank you for that. Now, the last question is from me, and I just want you to give 2 quick points, 2 quick things. This committee needs to deliver recommendations, and we want to present things to government to help push this agenda forward. Think about what 2 things each of you would like to see us put in our report to help us make those recommendations to government. So I'm going to start with yourself, Shanthi, just because you finished the last point. What 2 things we want quick fire? What 2 things would you like to see after the discussions today?
I mean, I think you could have a million specific, individual, tangible things, but the one thing I would say is you need new legislation to make clear how human rights law and other law applies to maternity care, and make sure everyone from frontline healthcare professionals, managers, commissioners and regulators understand that safety, accountability, freedom of choice and equity need to be at the heart of how NHS delivers maternity care.
Fantastic. Thank you for that. Professor Knight?
I've already said my 2. So funded pre-pregnancy care. We know that 90% of women can benefit from pre-pregnancy care and advice. And my second would be real-time data monitoring for maternal morbidity to allow us to respond when things are going the wrong way, but also recognise when we put in interventions that are effective so that we can scale them up and spread.
Fantastic. And Sonah?
I would say support support for our workforce to develop their anti-racist skills and competencies and confidence, so they are better able to support black birthers, and the community is involved in the design and delivery of services, and that is met with sufficient long-term investment.
Thank you so much. Can I thank the 3 of you? It's been absolutely incredible having you here today. And thank you for really holding this committee's attention. So thank you. And I'd like to say a special thank you to Sarah, who also has made a fantastic guest appearance on our committee. And on that note, I'm going to say order.